joining today. This is the March Journal Club. Today we're going to discuss this paper, which was published earlier this month in the American Journal of Sports Medicine. So it was published on the 3rd of March 2021. The title of the study is Hip Arthroscopy versus Physical Therapy for the Treatment of Symptomatic Acetabular Labral Tears in Patients older than 40 years of age. The purpose and hypothesis. So the main purpose was to perform a randomized controlled trial comparing arthroscopic surgical management in patients with symptomatic labral tears who were older than 40 years and did not have any evidence of severe arthritis. The hypothesis was that hip arthroscopy would not be more clinically effective than physical therapy in these patients. So their methods, their selection criteria. So this was a single surgeon parallel randomized controlled trial enrolling consecutive patients between December 2013 and July 2018. The inclusion criteria was 40 years of age as a minimum, where MRI evidence of a labral tear was observed. And there was also needed to be a history and physical examination consistent with symptomatic labral tear, so positive Fader and Faber tests. Completion of at least 3 months of conservative course, willingness to be randomized. Exclusion criteria then consisted of significant osteoarthritis, and this was graded using tonus grade classification, tonus grade 3. Any suspicion of acute or extra-articular hip processes or back processes, or unexpected pathology at the time of hip arthroscopy. Also, people with dysplasia by the center edge angle less than 20 degrees were excluded, as were anyone with previous hip surgery or any contraindications to either treatment arm. A sample size calculation was referenced, and this is based on a previous study of 80 patients needed to detect a 10-point difference in the modified Harris hip score. So the authors expected a 9 to 13% loss to follow-up, and so the aim of the study was to enroll 90 patients for this study. The randomization methods. So again, all labral tears were identified. At that point, then. All patients were required to undergo a minimum of 12-week non-operative management, and this included corticosteroid injections and a minimum 8-week supervised physical therapy. Where this was not effective, then patients were assigned by the research coordinator on a 1-to-1 ratio to either a surgical and physical therapy group or a physical therapy alone group. Crossover was permitted, and this was only if there was a completed minimum 14 weeks of physical therapy. An independent physical therapist determined this, where there would be no further improvement from the treatment arm. And so their outcome methods, then the primary outcome was 12 months after randomization. The outcomes were gathered from the modified Harris hip score and the IHOT 33. Secondary outcome measures then were assessed at baseline, 3 months, 6 months, and 12 months after randomization. Included the hip outcome score, activities of daily living, the non-arthritic hip score, lower extremity functional scale, and the visual analog scale for pain. Statistical analysis, so linear mixed effects models were used to measure the improvement trajectory across the study period. The data was then analysed using intention to treat analysis, modified as treated analysis, and treatment failure analysis. And secondary analysis was also undertaken to assess for surgical improvement of tonus grade 2. And this was a subset of the entire patients, so the surgical patients and those crossover patients. The results, there was 90 patients enrolled. 7 did not undergo their assigned protocol, and there was 2 lost to follow up for 12 months. So in total, 81 patients were included in the final analysis, 42 in the surgical and physical therapy group, and 39 in the physical therapy alone group. There was a 63.6% crossover to surgery from the physical therapy alone group, and this happened at a mean of 190 days post initiation of the physical therapy protocol. The average age overall was 49.4 years, and it's ranged from 40 to 67. So for their primary analysis, for the intention to treat analysis, the results are presented as adjusted mean differences between the 2 study groups. And overall, the result was that the surgery and physical therapy resulted in significantly higher mean IHOT 33 and modified Harris hip scores compared to the physical therapy alone group. And this was seen both overall across the treatment period and at 3, 6, and 12-month periods. The authors then performed a sensitivity analysis in the form of an as-treated analysis of the data, and the results were consistent with the results from the intention to treat analysis, that being that the surgery and physical therapy resulted in higher mean IHOT 33 and modified Harris-Hip scores compared to the physical therapy alone group. And then finally, the authors performed a treatment failure analysis whereby they assessed the patient-reported outcome scores between those patients randomized to either group at 12 months. And again, the surgery and physical therapy group resulted in a significantly higher overall IHOT 33 and modified Harris-Hip score compared with the physical therapy alone group. Finally, then, the secondary analysis to assess whether the tonus grade 2 patients experienced surgical improvement. So there was significant improvements in the main outcomes for tonus grade 0 and 1 and tonus grade 2 at 12 months post-surgery compared to baseline. And then comparing the patient-reported outcome measures between the two groups, there was tonus grade 0 or 1 had a significantly higher IHOT 33 at 6 months compared to tonus 2. And the tonus grade 0 and 1 had a significantly higher modified Harris-Hip score, 3 months and 6 months compared to tonus grade 2. So at 12 months then there was no difference really between either tonus grade. The author's limitations, there was a high crossover rate, per protocol analysis was therefore not feasible. It was possible that some patients may have had bias for either surgery and physical therapy or the physical therapy alone. There was no midterm or long-term outcomes able to be reported. It was a single surgeon study, so it limits sample size and generalizability, and blinding was not possible, as is the case for randomized controlled trials comparing surgery versus non-surgery interventions. So in conclusion, the study hypothesis was refuted. Hyperarthroscopy plus post-operative physical therapy leads to a better patient-reported outcomes at 12 months in patients greater than 40 with symptomatic labral tears and limited osteoarthritis compared to a physical therapy alone group. And also, age greater than 40 should not be considered a contraindication to arthroscopic acetabular labral repair. So that's just a general overview then. So I'll hand you back now to Mr. Carton so we can open the discussion.
Okay, David, thanks very much. So we'll just go through the paper as we normally do, talking into different sections. So again, the title of the paper is different than the last few papers that we've reviewed, in that it doesn't highlight the conclusion or the main results of the actual study, and refers more to the aim of the study. So this is I guess if your results are extremely strong, there's a temptation nowadays to try and incorporate the results into the title. Maybe because of the high crossover in this study, the authors maybe felt just go for a generic title, looking at the aim. Any comments on the title, guys? Or thoughts on that?
I'm thinking just on the title, the way that they're saying that what they're looking to analyze is acetabular labral tears specifically, whereas we see in the inclusion criterion and in the characteristics table that kind of, I suppose, that both groups had radiographic cam lesions and pincer lesions. So I was wondering why they chose labral tears specifically when there were also cam and pincer lesions. And as well as that, then in the assessments for the inclusion criteria, they did mention, yes, more of your labral type symptoms like the catching, the clicking, the popping, and that. But I suppose with your FAI, you're also looking at your groin pain when sitting and standing from seat position stuff. So I was just wondering why they did it specifically for labral tears as opposed to just FAI in general.
Yeah, yeah, very well spotted. And I think what we do is when we go down into the method section, we look a little bit more into the actual surgical technique, and on top of that, when we go down to actually look at the radiographic analysis, they didn't actually include any of the angles, such as the lateral center, the median, or sorry, the mean lateral center edge angle or the mean alpha angle between the groups. So that may have directed some of the results. So yeah, let's look at that once we go into into the methods. So anybody else have any comment on that? Well picked up that this the title suggests labral tears as opposed to FAI. Okay, so look, let's go on to the main aim. Obviously, the background and the purpose of this randomized controlled trial. This remains a controversial area in the management of FAI as to when somebody presents with symptomatic FAI, and especially if they've had a 3-month failure of conservative measures, is the outcome from surgery better in the longer term or even the shorter term than the outcome of non-surgical approaches? And as the background alluded to, there are already 3 or more now randomized controlled trials that have looked at this issue and are still looking at the issue. And again, the results I feel overall are still not clear cut. Despite 2 of the big randomized controlled trials from the UK demonstrating superior outcomes with surgery in the earlier stages, maybe 1 or 2 years. The original RCT that was alluded to in this study was by Mansell et al. And again, it brought quite a lot of brought some controversy to the FAI scene, and the fact that again there was an enormous crossover, and they felt a lot of the results from that particular study were felt to be inaccurate. So, okay, so regarding the aim of the study, I think the aim is very clearly set out, so the primary aim and the secondary aim again is a classical way of looking at these. What's the primary aim of the study and what's the secondary aims? And so anybody any comment on the actual aims of studies and how that was set out? We feel they were very clear to begin with.
Yeah, I think it was clear.
Okay, so the primary outcomes that they were using again are suitable. They started off from their original submission as a randomized controlled trial, specifying the modified HARS-HIP score as their primary outcome, and later changed that to introduction of the IHOT 33. Given that the study started in 2013, which I think was around the time the IHOT came out, so it's probably very reasonable that they included that as another primary outcome and introduced that into the results of the study. So they also used secondary outcomes. A lot of questions these patients were answering because it included the non-arthritic hip score, the hip outcome score, and but when I looked at their submission originally to the and if you look at the clinicaltrials.gov submission, they also had secondary outcomes were range of movement and also had strength testing as well, but obviously haven't included any of this in their actual study. Okay, so let's just go on to onto the methods. Okay, so any comments, anything I've said so far, or are happy enough to just move on?
Yeah, happy enough.
Yeah, that's fine.
Okay, so let's just talk about the actual study design. I think, David, I assume this is followed a very standard design of a randomized controlled trial looking at surgical and a non-surgical outcome.
Yeah, I mean, I think the methods and the way they kind of assigned people to each group was appropriate and everything. Now, they didn't give any indication of how the randomization or how people were assigned to each group.
Yeah, I think it came across. I think it did come across the fact that it was electronically assigned somewhere.
In a Excel package, it says.
Oh,
okay.
Yeah.
There you go.
Okay, so inclusion criteria. Okay, so obviously the aim of the study was to look at over 40s. Okay, so that's obvious. And as Sarah pointed out, the title includes the treatment of acetabular labral tears. So they were quantified as being complex, a simple different type of classification of labral tears. One thing I said, I've noticed in the inclusion criteria, history of consistent with symptomatic labral tear, at least one of the following symptoms. So it means that a patient to enroll in this trial simply had to have one of these. So clicking itself to me would not be, on its own a strong enough symptom to consider having somebody who's randomized to surgery. So again, having so to me the history was just a little bit. It was inconsistent with what I would view as having enough symptoms to warrant surgery. He certainly, in most of the studies that you would read that reported on symptoms, I mean, patients characteristically will have significant amounts of pain levels affecting their quality of life, affecting their hip function, restricted range of movement, and all of these things I think are very important and you come to a general feeling that a patient has now reached a stage where they need certain intervention. And again, of course, the work consensus that a lot of people have signed up to would indicate that, and so that you have to have obviously a strong history of these that have not responded to conservative measures. Okay, so but again, they've included the physical examination, FIBER. We know from our own results, about 3/4 of patients will have a positive FIDER in examination, and about 50% will have a positive FIBER. And again, the fact that the patients have gone through 3 months of non-operative management and willingness to be randomized. So these are all good. What do you expect for inclusion criteria? The only thing that I would say about the patients who were excluded was the fact that anybody who was between 20 degrees and 25 degrees of lateral center edge angle were actually included, and this would be considered by most authors either borderline or actual dysplasia. So and I think there were 6 patients in the surgical group who had evidence of dysplasia, and so again, we're now introducing what you mentioned at the start, Sarah, is that the focus in the title maybe being on symptomatic labral tears, because they're now introducing patients with tonus grade 2, which is early osteoarthritis, patients with a center edge angle less than 25, which is dysplasia, and then obviously all other patients in there are likely to be some degree of impingement or potential instability. So therefore it's more of a mixed criteria, pathological criteria that's included here. So therefore they've gone for the symptomatic labral tears being their main pathology to look at. Okay, regarding inclusion exclusion criteria, guys, anybody any comments on that or anything they want to add?
No, I think just what I was going to say, it kind of comes up a bit more later on though when you look at the methods. Just that I know they included people who had essentially failed 3 months of non-operative management, and I just wonder how that would have affected the patients going into the physical therapy treatment arm of the study if they had already not gotten any benefit from 3 months of that type, and would they, if that could affect then the crossover rate?
Yeah, I agree, but I think the general consensus in the hip arthroscopy world is that before you would be in a position to offer or randomize somebody for surgical intervention, that would have to have failed at least 3 months of appropriate conservative treatment to ensure that this wasn't some sort of temporary issue with the hip that would settle with non-operative means. So once you've reached that stage, yes, I agree. If you're all of a sudden randomized again to further physiotherapy after having 3 months that haven't worked,
especially
you may
especially when you
less
know surgery is on
and
offer.
want to cross over.
Yeah, and when you know surgery is on offer at that point.
Yes. Well, I guess that's the reason why there's such a big crossover rate in all of these randomized controlled trials, is that because they're starting off with patients who've already received physiotherapy, and again, there's that sort of misunderstanding that all physiotherapy is equal, and so a lot of these patients may have just been having sort of home exercise programs at home, just doing things themselves with a varying level of compliance. So whether they really received physiotherapy, supervised physiotherapy, that's difficult to say. Did anybody review the Appendix A or Appendix B, the physiotherapy rehabilitation programs?
I did.
Who said that?
Karen.
Karen, that's okay.
Yeah, no, but they actually didn't give the first 3 months program in it.
Okay.
They gave the post-operative rehab from surgery and then the physical therapy arm of the study, but they didn't give the first 3 months. No.
Okay, so yeah, go ahead, Michael.
Sorry, Pat, just I would say it would be quite a vague program, in terms of detail around actual exercises or sets or reps or anything like that. You won't find any of that in there. It is, it's guidelines really. So there's a lot down to interpretation from that.
Okay. And one of the things that I think I would add there is that, maybe not right at this point in time, but when we go into actually looking at the rehab programs more detail, or the treatments more detail, is that they didn't. There's nothing regarding compliance that I could see through the study as to how compliant patients were at different stages, and with the rehab. And you know, for rehab to work, there has to be compliance. You know, if they've set out that they're going to have people come back to be supervised physiotherapy on a weekly basis, you know, how many patients were able to comply with that fully, and are the patients who crossed over patients that maybe weren't compliant in the first stage. So there's a bit of information, I think, regarding that missing, but we'll come on to that in a wee second. Sample size calculation, again, David brought that up in his presentation, Michael, I always usually go to you in this, but I think that looks very straightforward. They've done a calculation based on some of the previous research that they've done, looking at a power of 0.8 and an alpha angle of 0.05.
Or a p-value of, an alpha level,
yeah.
A p-value of 0.05, yeah.
Okay, and what they're stating here is that they needed 80 participants, so you're expecting possibly 40 in each group, to show a 10-point difference in the modified hardship score between cohorts. So, and what they're looking for, I mean, a 10-point difference in the modified hardship score between preoperative and 12-month outcomes, or maybe at any stage, but would be slightly greater than the minimal clinically important difference that has been reported for that particular outcome, and has been referenced by other journals. Other journal articles. What we have shown in some of our own articles is that that really you should actually calculate your own MCID for your own cohort. It's much more accurate doing that, because the MCID fluctuates an awful lot between different cohorts, and to simply use a 10-point difference maybe not apply to this patients, although because it depends on their age, depends on their activity level, lots of things that will change the MCID for different cohorts. Okay, so. Okay, randomization. Anything you want to add, David, at this point in time in the discussion regarding the randomization process?
No, I don't think so. I mean, I overlooked the fact that they were randomized electronically. That was the only kind of comment I had on that. So no, I think it was okay. Okay.
Okay, so last paragraph in that randomization section, they focused on, which to me is one of the main issues in this study, is the permission of patients to cross over and obviously remain in the study, and that's forms the basis of their intention to treat analysis. So the David, or if you remember Damien Griffin's paper, I remember Damien Griffin presenting his paper at the Isha conference. He did the randomized controlled trial, and there was, and I can't remember exactly what the crossover rate was. I think it was somewhere in nearly late 30s or 40s, and there was mentioned at that time that a crossover rate of greater than something like 28% almost really destroyed any validity to the results once you had that high level of crossover from one treatment to the next. But in this study, we have almost a 63% crossover. So when we come to look at the results, I mean, can we actually interpret the results based on such a high level of crossover as being accurate?
Yeah, I think it's even less. I mean, I think the Center of Evidence-Based Medicine suggests that a rate greater than 20% is a rough guide to the number which may invalidate final results. So yeah, as you said, this is 64%, which is much higher. Damien Griffin's, I can't remember what the percentage was in that. I think it was maybe 27 or something like that. It was in or around kind of the borderline.
Okay.
But yeah, greater than 20% is what the Center of Evidence-Based Medicine suggests would invalidate the final results.
Okay, so let's go on to look at the statistics and got the outcomes there. We've talked about that already. Okay, so just trying to talk through the stats. I mean, there seems to me, from my point of view, there are three main ways they've looked at the primary outcome here. Numa's looking at what's called the standard intention to treat approach, and we came across this in one of our other reviews a few months ago, and my understanding of this is that the whole idea about randomization is obviously to try to avoid bias between the groups, so that everything is kept as similar as possible. So therefore, any difference in outcome is purely due to the intervention rather than anything else. And therefore, when you randomize patients to these groups, that they should remain in those groups, irrespective of compliance to treatment or crossover, and therefore the results they get still remain within the randomized groups. And so therefore, even though the fact that there's 63% of the PTA group crossed over, that their results would still be interpreted as part of the PTA group, despite them having surgery and despite the surgery actually possibly affecting the outcome more than the physical therapy they had in the first place. Is that your understanding, Michael and David and Karen, or anybody who has a good idea about the intention to treat analysis?
I think the intention to treat analysis does kind of take into account or kind of counteract the effects of patient crossover, but I think that intention to treat analysis might become invalid in the setting of excessive crossover, and particularly where there's one-way crossover with the surgery versus a non-operative randomized controlled trial, and it's always going to be a flow of patients in one direction. So I think it's probably the standard for analysis, and it has to be reported for these randomized controlled trials. And I think in the case of excessive crossovers like with this, it's probably kind of clouds the results a little bit, and I don't know if it can be as accurate.
And Michael, is there any comments?
I think your description is correct, and it works both ways, of course, as well, in terms of those who were intended to have surgery but didn't go on. So I think it's 3 of the 46. Those are still included in the surgery group at the end. It's, it includes anyone that they intended to treat with surgery or intended to treat with physiotherapy, and that's the groups that determines those two groups. Clearly, as David said, it becomes quite flawed, I think, when you have such high crossover that can affect it, and that's why they do these sensitivity analyses.
Okay, so if we move on to the sensitivity analyses, and this is where we look at two real areas here, wasn't it? There was basically an as treated assessment, and then they have the treatment failure analysis. So again, my understanding is that's rather, so the intention to treat, they're looking at really the 12-month outcome or the final outcome, and looking at an as treated. They're taking the physical therapy group before they crossed over and used their outcome scores at that point, which would suggest that would be the point at which they had maximal benefit from the physical therapy. And to try and keep 2 parallel lines of analysis going to separate sort of the surgical outcome from the physical therapy outcome, but still retain as much of the patients in both groups. So essentially, you're protecting your randomization, but you're using that endpoint as the point before crossover, as opposed to the 12-month outcome, and you're assuming that the endpoint at crossover is essentially their equivalent to the 12-month. And again, obviously the problem with that is that you're including patients then who have not quite obviously have not benefited from physiotherapy, which will bring the physiotherapy results down. And these patients may also be patients who may be resistant to any type of treatment, or may have other confounding factors that are giving them a bad result. And if they cross over to the surgical group, they may in fact then negatively affect the good outcome of the surgical group as well. So wherever these patients go, they may have a negative effect on the results. So is sensitivity analysis a good way of actually improving the accuracy of the results, or is it just another sort of false line of analysis?
I think in this particular example, I mean, in this study, there's the sensitivity analysis where it's the as treated analysis, looking at the 2 different groups. There's obviously huge differences between the two, the numbers of cases in 2 groups. I mean, I think there's about 15 people left in the physical therapy alone group compared to a cumulative kind of 70 in the surgery group. Yes. So, and there's no indication really of the differences in baseline scores between those 2 groups, in terms of their pathology or the severity of their symptoms or anything like that.
But the other thing is that the power analysis that was done at the start that was going to differentiate between the results of the groups then becomes ineffectual when you have 70 in one group and you've got was it 12 or something in the other group? So
yeah.
So again, the analysis then becomes underpowered, and again, how accurate then are the results? So to me, this is the crux of this paper: is that the complexity of the statistical analysis makes it very difficult for certainly for somebody like myself to work out as to whether these results can be whether they're accurate or whether they're not. And so just the fact that we're producing statistically significant differences between groups may mean meaningless, really. And so, Michael, what do you think of that?
Yeah, just a couple of points. I suppose I think the authors acknowledge it in the discussion that the real value may lie somewhere between the treatment failure analysis, which tends to favor the surgery group, because you're really comparing. You could be comparing 2-month scores or 3-month scores of the physical therapy group just before they transfer over to surgery. You're comparing them then when they're probably at their worst. They've decided this isn't working for them, to 12-month scores for surgery, and they acknowledge that does favor the surgery group. On the flip side, the as treated analysis tends to favor the physical therapy group a little bit, because the harder cases, the more difficult to treat cases will transfer over. And the ones who had surgery that may have been difficult to improve have to stay in the surgery group. There's no transfer the other direction.
Yes.
So when you have statistical significant results in both of those situations, and the real value lies somewhere between them, then I guess because the results are quite strong in this case, it's a bit more clear to me what the findings are. If they were a little bit more inconclusive, then it would be hard to know, I think, what. Back to your point on power, you're right that the power analysis doesn't support smaller groups, but the power analysis is mostly there to try and reduce a false negative, as in not finding a difference when there is really a difference there. Most of the case here, there are significant findings, so that kind of indicates that the power was high enough to find those findings as being significant, if that makes sense. So those are just some kind of points on that, I think. And one point on that side, Pat, I don't think that the timing of surgery is mentioned in the paper. Maybe someone might correct me if I'm wrong in that, but these are not 3 months post surgery necessarily. These values, David, I don't think they're 3 months post randomization.
Yeah.
And I know in other papers in this area, sometimes the timing of surgery was quite delayed. It wasn't, a week or two later, and I don't think they mentioned that. And it's just, I get a little bit surprising. I suppose the 3-month scores are as good as they are. And that it doesn't tend to get better, but of course, once you get into 12 months in the modified one, you're having crossover involved, but you don't have it involving it here. But
yeah, it'd be good to know that. I do know that your 3-month scores do tend to be actually pretty good. Even in our cohorts, the activity level certainly would be back up, so that you'd expect the sports specific scale and the HOS, for example, would be low, and then increase, and it seems to do that.
Yeah.
So the results, they look reasonably. I mean, certainly our results seem to improve from 3 months up to a year, and then improve again to around 2 years, and then they stay pretty constant after that.
But my understanding with the intention to treat analysis, then when you have crossover, although the crossover happened on average 190 days in, there is possibly some people who had surgery at 11 months and were included in the surgery group for their 12-month score, and it could have been 1 month post-surgery.
Yes.
Yeah. So okay.
Absolutely. And they didn't give us enough information to look at that, and I think it goes back to some of the other information I think that was missing. Was first of all was the radiographic analysis, and I think very important to look at the difference between groups, because they have measured the alpha angles, they have measured the center edge angles, and they've simply just put down radiographic cam lesion yes or no, radiographic pincer lesion yes or no, and to me, the size of the cam, or the mean size of the alpha angle, again would indicate a more significant problem, and therefore, was there a difference between the surgical group and the physical therapy group regarding these type of parameters? And I think that would be important, because it does I wonder why it's not in there. They've just said yes, there's a cam lesion, yes, there's a radiographic lesion, you know, and to me, more details would be important there.
Sorry, just to add to that, Pat, there is a table in the supplementary files that looks at kind of the distribution of femoral acetabular impingement between the crossover and non-crossover patients.
Okay.
But that's the only kind of information that's given, and there is a significant difference there. There was a greater percentage of patients with mixed impingement who did cross over to surgery.
Compared to the people who didn't cross over, or compared to the people who, okay, so the people who ended up crossing over for surgery had more evidence of clear FAI pathology than the other patients who were more happy or more successful with physical therapy. And so, and you know, and I think that this is the information that really we need, you know, and we've got to be sure that, you know, that the patients who are having physical therapy do have the same morphological and pathology as the surgical group, and the patients who cross over compared to the people who didn't cross over. I think we should have had more information regarding the extent of the pathology, and also the tonus grade as well. And so that sort of information, it sort of frustrates me when it's not available, because it doesn't allow you to look into the groups properly. Okay, so one of the other things just I meant to say just regarding when we started regarding the introduction to this was and it comes into the discussion as well, is that I think it's sort of there's no reports or reference in there that talk about studies that have demonstrated good outcome in the over 40s, because I mean there are studies that have shown that age is not as important to outcome as previously thought, and and that it's more due to articular cartilage damage and the presence of OA rather than age. In the absence of OA and the absence of dysplasia, that age in many cases is not as relevant as first thought. And they didn't have that balanced approach to their introduction or into the discussion regarding the positive reports for over 40s. So I always think it's good to represent both sides in your introduction. Okay, anybody, any comments? Anybody else? Myself, David, and Michael, and Karen, I've been talking a lot, so it'd be nice to hear anybody else's opinions at this stage.
Yeah, to be honest, Pat, I struggled quite a bit with the stats. I just don't have that experience looking at them in the way that they've been analysed so far. But it is good to get the opinion of the experts on stats, and it breaks the paper down a lot better than just purely reading the text in it and taking it for face value. So with it broken down a little bit more, it kind of, I suppose what's been written down and what actually you can read between the lines are two totally different things, and that's been quite enlightening for me.
I suppose just one other thing, I suppose the questionnaires, I'd like to just know a little bit about how they were carried out. How did the outcome measures? I don't know how you guys do it or how you question them, but when you're talking about, you know, they talk about kind of the psychology behind some of the questionnaires used and how they went from using one of them onto another one when they talk about psychometric changes or something like that. So how do you go about actually asking the questions without influencing the outcome measures? So one of the things when you talk about pain, you know, if you ask it in a certain way, surely the outcome can be influenced a little bit. That's just the only question. So I'd like to know how you would do it in your previous studies.
Okay, David and Karen can answer that one. They're at the cold face of outcomes.
I'd say that I think most of those studies are validated. Their hard copy will say evaluated stuff for the patient to fill out themselves, pen and paper type thing. And so I can't imagine that anyone or the person, whoever was collecting the outcomes, would have, you know, went through the question, or, you know, the tone of voice or anything like that would have influenced their answers. I think it's probably pretty accurate with respect to how that patient was feeling at that time, considering it is validated for pen and paper. And I didn't say that they completed them by pen and paper, but I assume that's the way. Yeah.
And would it be carried out before any interaction with either any therapists or
well, I suppose for baseline, you mean, if you were to get baseline?
No, for the follow-up, would they ask them before, say if they were finishing the program after 1 year, would it be on review, or would it be before or after the review with either the therapist or the consultant? Or
well, for us, I suppose the baseline probably gets done before they have any kind of interaction with the consultant, and then follow-ups will be done also. If they come back to clinic, they will fill out their questionnaire before they come in and see the consultant, or if they don't have to come back, like longer-term follow-ups, maybe 1 year, 2 year, 5 years, where the patient might be in a good enough position that they don't feel that they need to come back and have a clinical examination. They still want to fill out their outcomes. That would obviously be done without any interaction from us. So,
Yes, yeah, Michael, you've touched a very important question, because we take it for granted that these outcomes are all done the same way and done properly, and we do take steps to try and do things. I'm not involved in the outcome collection at all as a surgeon, and but you're right. I mean, if I sat with the outcomes in front of me and went through them with the patient, of course I could influence the results. And so you're not meant to do these outcomes on the telephone with the patient. You're not meant to influence or direct the patient in any way. And I'm sure that does happen. And but it's very important that, and you mentioned the importance is to have the outcomes filled in before they come and see me. So before they've even met me, all of the outcomes are completed. So we're getting the patient is left to do that for themselves. They just ask politely to complete the forms, and so but what you do notice is in post-op, obviously when the patients have gone, at the end of the day, I can look through the outcomes myself and see what way they've reported things, and and I'm quite sure there's plenty of patients come into the clinic, and had they left the clinic would have reported those outcomes in a very different way. So you get a lot of people who come in who have other problems, who have back pain or who have problems in their knee. And it affects their outcomes because they're not able to go up the stairs well. They're not able to, their pain score is 7 out of 10, but it's nothing to do with their hip, So quite often the outcomes in many cases are complicated by other things going on in the patient's lives that would often give you a lower outcome result, even though it's nothing to do with your hip, So, and of course, yes, if you're sitting in front of the patient, you could influence that. But when you're doing so many outcomes and so many patients, these outliers become less relevant, and the body of evidence you have from 3,000 patients completely outweighs the outliers, which may be in a couple of hundred, So therefore, you let people get on with doing it themselves as independently as possible, and that's why I came back to blinding, So I mean, obviously, there's different levels of blinding in these trials, but if we were writing a paper, I was writing a paper, I'd be completely blinded to the outcomes that were filled in. I'm not aware of them, I'm not involved in them, and when I get the results, they're just numbers, So blinding can be done certainly from the surgical side of things, So you don't have to be involved in it. Any other comments and outcomes there, guys? Karen, anything else? Do you have?
No, I was just going to explain as well there to Michael, the reason that they added in the extra questionnaire was that modified Harris hip score that was originally developed for people with much worse kind of hip osteoarthritis. So it has what's called a ceiling effect. So people who aren't as bad as what we'd see it in the clinic tend to score very high on the outcome even before they've had treatment. And because that's a limitation, the authors have added in a second one, which might be more relevant. So I think they did well there to kind of counteract that problem.
Okay, so let's just go on to the discussion. I think the discussion is fairly straightforward. I mean, they have obviously outlined both in discussion and in the areas of limitations and strengths. They have focused on many of the main areas that we've actually talked about today. The strength of the study obviously is that it's in an area that is remains controversial as regards to the treatment of older patients with FAI, and the strength also is that they have a high follow-up rate of, despite patients crossing over, they've managed to keep 90% of the patients in at their 12-month follow-up. So they do put down as limitation actually this being a single surge series, but again, I also think these also have strengths compared to multi-center studies where you have very different surgical techniques going on, very different physical therapy techniques, different cultural changes between groups and different cohorts. So I think sometimes there's more strength in a large single surgeon studies series than negative effects of it, and they obviously they mentioned about the high crossover making a per protocol analysis infeasible, and again the per protocol analysis is my understanding that is that really just what you're doing is you're then analyzing patients from the treatment they've received as opposed to the group they're randomized in, and that again can create a selection bias and again loss of power, as we brought up and highlighted the fact there's only 12 patients then I think ended up in the physical therapy group. So the last thing was about the tonus subgroup analysis. We didn't really touch on that, but my feeling was again there was a small number of tonus 2 patients compared to 0 and 1, and it becomes difficult when the groups are so uneven, especially with low numbers, regarding the power of that analysis as well, and how accurate that is. But and the fact also that there was a difference at 3 and 6 months, and in fact there was no difference at 12 months. Again, it seems quite odd when you'd expect it, if there was going to be a difference, the longer from surgery, the longer treatment, you'd expect to see that difference more defined. Anything, guys, that's regarding the strengths of the study that you want to support, or anything regarding limitations that maybe we haven't brought up or that hasn't been highlighted?
I suppose I was just wondering, just to put it to yourself, Mr. Harton, just about the inclusion of the patients with tonus grade of 2 into the study. Do you think that might be appropriate? If you were to do it yourself, would you consider that? And I know that this is an over 40s study, so I think they mentioned at some stage, they expect that patients who are symptomatic over the age of 40, might be more likely that they'd have like tonus grade 1 or 2, but do you think that might be a limitation of the study?
It is. Now they have said in their exclusion criteria, they have excluded people who had a depth on their AP X-ray of less than 2 millimeters, and so 2 millimeters has been a cutoff that has been reported, that if you have a loss of height of the joint space by more than 2 millimeters compared to the other side, then your outcome from surgery is less likely to be successful. So they have taken that cohort out that may also qualify as tonus 2. So certainly in our study, if you want to have a pure FAI study, then my view is you have to exclude tonus 2. You also have to exclude any patients with lateral center edge angle of less than 25. Because you're bringing in borderline and mild dysplasia as well, which can affect your outcome. So my guess is, because the numbers were quite small overall. I mean, this went on for 5 years, so they've been recruiting for 5 years. They've managed to get 90 patients over 5 years. 8 of those patients had dysplasia. And not too many patients altogether had tonus 2. Did anybody have that number?
19.
19. So if you take those 19 out and you take the 8 with dysplasia, there's 27 patients out of your study. You're below your power analysis level. So I guess, look, they've done their power analysis. And it may have influenced their selection criteria, which again, as you say, I think weakens the strength of the results with respect to FAI. Okay, so in conclusion, so the authors very clearly conclude that relative to physical therapy alone, hip arthroscopy with post-operative physical therapy leads to better patient outcomes at 12 months in patients older than 40 who have symptomatic acetabular labral tears and limited radiographic OA. So as such, they recommend that 40 years of age should be considered for acetabular labral repair in this population. So any comments on that strong conclusion? Does everybody feel the same?
I think one point on it, Pat, it relates to the fact that if you read the study as a whole, I don't think you're going to be misled on what the outcome is. But if you read that conclusion on its own, it isn't clear that these are people who have not responded to 3 months of physical therapy.
Yes.
And if anyone took that and made it into a newspaper article or a headline article, you know, that's a very key part. Before the 3 months of physical therapy, they had symptomatic labral tears and they were over the age of 40. If there were 200 and 100 of those came back after 3 months and didn't need to go further, they're not included in the analysis. So
right.
There's an important missing couple of words there, I think, to really avoid it being misinterpreted in that way.
Okay, so you're saying that that's a significant proportion of people coming to their clinic who had 3 months of physiotherapy and recovered from that, are being the stories being sort of tilted against that in a way that they're being forgotten, they're being excluded, and so these people actually have done very well from physiotherapy, and it's the people that failed physiotherapy are now being randomized who may have more pathology in the first place.
Well, I'm clearly hypothesizing on that number,
yeah.
But it's just, it says basically that these people had symptomatic labral tear and they either got physical therapy or surgery, and surgery
yes.
worked better. Yes, in this group, once they had 3 months and that hadn't worked for them already, which Karen mentioned earlier.
Yeah, and so absolutely, yeah. And again, would have been important to include throughout this 5-year period how many patients have come to the clinic, have had 3 months physiotherapy, and have actually done very well. Okay, anybody else? Any other comments on the conclusion? Do our physiotherapists agree with that conclusion? Do you support that completely?
Yes, I'd agree, because I suppose at the start, even before they're randomised, they had gone through that 8 week of conservative treatment, with physio plus minus having an injection as well. So even before that, they would have gone through some degree of rehabilitation. So yeah, I'd agree with what Michael has said there.
The other thing, if they had the 24-week focused weekly supervised physical therapy from the outset, maybe less people would have been available for the trial. Maybe yes. more people would have got better.
Then their power will be completely off.
Okay, guys. Look, if there's no more comments, I think the randomized controlled trials and the statistic analysis goes with them. They're complicated, but again, they're trying to compare two groups as without introducing as much bias as possible right from the outset, and it is difficult when you have that crossover. It makes it very difficult to interpret, I feel, and so I think this answer regarding physiotherapy, the real role of physiotherapy in FAI, the real role in physiotherapy in people with dysplasia or people with early OA, it still remains controversial and still remains unanswered, So, but you can see how difficult it is to actually set up a proper randomized control study and control those groups to be able to have the real data that you want to be able to show those differences. It's very difficult, So we do need more of these studies, and it's great that people have put the time into doing this, So that for one has to be commended. Our next paper, Karen, is 2 weeks' time, and it is. Do you know the title?
Yeah, so it's a comparison of gluteus maximus, biceps femoris, and vastus lateralis electromyographic activity in the back squat and barbell hip thrust exercises.
So what this paper is, this paper was sort of caught my attention. Derek O'Neill, one of the physios, said it, and really the reason why I think it's relevant is because I spend half my time telling people not to do squats, and especially with weights, and they all ask me, well, how am I going to strengthen my glutes? And now I think I have the answer. They've got to do loaded hip thrusts. So I'm sure there's many ways of achieving that, but the paper in 2 weeks' time is going to look at the differences between glute strength and glute activity using the squats and using hip thrusts. And I think we may have, based on that, on the success of that paper, we may have an alternative to squatting. All right, guys. Okay. See you in 2 weeks' time.